much. We'll move swiftly on to the next panel, to the next technical session. Before we go into that, let me also just recognize the presence of another distinguished partner in the room. Just welcome the Director of Software and Biometrics from the National Identity Management Commission, Engineer Lanre Yusuf. Thank you for being with us here today. And I'm sure you'll give us a chance to give your address in the next panel session. So swiftly moving on, we'll take the next technical session, which is the use of digital identifiers in health information exchange and predictive healthcare. And to moderate that panel, let me call on my other colleague, Emeka Chukwu, to get us started. Thank you.
Thank you very much, Juliet, for the wonderful work you've been doing since morning. My name is Emeka Chukwu. I work for Health Enabled as Senior Digital Health Advisor, also co-convening this with Juliet and Inyobong. So welcome everyone. We are really happy that you are here. This is something that's very dear to us. So this panel, I will go forward to invite the panelists who are already here. So I will start by inviting just a second. So I'll start with the people online. So we have Yusuf Daniju. Yusuf is based in Germany, and he works for a technology company in Germany. Just a second, I'm trying to pull up the details. So Yusuf is a dedicated software development professional with a decade of experience, including 5 of those specializing in healthcare interoperability. He's a Nigerian. He's a senior software engineer at Doctolib, and his work is focused on using German policies and frameworks to design software systems, especially around prescription management of system. He uses FHIR a lot. He's been to Dev Day. Those of us who are conversant with FHIR will understand that Dev Day is that pinnacle of events that if you go and present there, then you are considered a real FHIR expert. So we are really happy to have you, Yusuf. The other person I will invite here is also online. He used to be my boss many moons ago. His name is Olasupo Oyedepo. He's the co-founder and the first director of African Alliance for Digital Health Networks, a peer learning network recently set up to provide coordination support to continent's digital health ecosystem. The African Alliance helps to incubate and grow human, technical, and entrepreneurial capacity in Africa to leverage the power of digital technologies in health across the continent. He has 20 years experience, over 20 years experience supporting and deploying technology in several sectors, of course, most of them in health sector. And his expertise includes digital health governance, project and program planning, and policy and strategy. He's also particularly passionate about country leadership and governance of digital health investment and activities in low and middle income country. He holds a master's in digital health governance and now completing his PhD focused on artificial intelligence. He is also a visiting lecturer at the University of Buckingham in the UK. So please welcome Shukwu. He's also online. The next person I will call is Ezenwadike. Ezenwadike is also online. He's a registered health information administrator and has about a decade experience in the health IT industry. His areas of expertise includes most of the standards that we are going to be discussing today: HL7, ADT, SIU, ORM, ORU. Don't worry if you don't know what all this means. That there are different standards that we use in the sector: CDA and SNOMED, NDC, Medispan, RX, NOM, LOINC, and a lot of value sets that they use in the US. He is currently working with CMedical to harmonize HL7 version 2 standards for messaging to FHIR. You see, those ones have standardized before they are now trying to go back to FHIR. So Ezenwa is an expert in systems integration, mostly in the health information exchange space, and has implementation of these in several states in the US. And he is currently working with CDC to improve compliance and compliance with the CDC national implementation guides and state compliance as well. So thank you very much, Ezenwa, for joining us. So now I'm going to switch to those that are online. So I will call on Bolu Watito Adeyemi, a technical advisor at Clinton Health Access Initiative, partners with the Global Digital Health Product Organization to understand the product functionality, align roadmap with countries' health strategy, and the need, and specialize in geospatial technology. Bolu previously worked in the fintech sector, where the use of interoperability standards such as ISO 8583 for card transactions on any financial institution terminal or platform enhanced customer experience. At CHAI, he's involved in digitalization campaign with the FMOH aiming and the subnational level and aiming to reduce resource duplication and increase campaign efficiency, working with Lagos State government to digitize operations of primary healthcare facilities to improve quality and access to care. He's proficient in standards such as GS1, ICD-11, FHIR, DICOM, HIPAA, GDPR, and NDPR. So thank you very much, Bolu. The next is, I'm going to call on Ajibola Matthias Jacobs. He has over 10 years experience transitioning from network engineering. He's now a cybersecurity expert, but also has previously worked in the space of, he's a consultant in ID for development, and he has expertise encompassing this domain, including engineering, vulnerability assessment, penetration testing, and more. Beyond technical proficiency, he actively champions cyber security user education program, empowering individuals to protect against cyber threats preemptively. So thank you very much, Matthias. So last but not the least, I have engineer Lanre Yusuf, who is the Director of Software and Biometric at National Identity Management Commission. We know that we're talking about the theme of this event is ID, and there's no better person or organization to be represented here than than NIMSI. So he's heavily representing NIMSI here. He's responsible for software development and biometric adjudication at NIMSI. He's a member of several technology and engineering organizations: Nigerian Computer Society, Nigerian Professionals, Computer Professionals of Nigeria, Nigerian Society of Engineers. He's a registered Korean member with a decade experience in IT, not just in Nigeria, but also in the US. Thank you very much, sir, for joining us. So at this point, without much ado, I will join the colleagues so that we can kick off this panel session. And I'm so excited and looking forward to this session. Just a second, let me pull up my questions. Okay. Good. So I will start as before. Let me start with my boss, Shupo Yedepo. Okay. As a digital health thought leader and a researcher in the field of AI in healthcare, we all know how AI is making a lot of wave these days. So the question I want to pose to you is there a role for artificial intelligence as we discuss health information exchange and standard? Because it seems AI is doing everything. Please just enlighten us, since your PhD work is in this area. Thank you.
Thank you very much, Emeka, and everybody else. Can you hear me?
Yes.
Okay, so I'm going to crave your indulgence to give me 3 minutes to share some slides with you. And then I would speak to whether there's a role for AI.
Yeah. Apologies.
Not.
Oh, yes. You can share the slide. Yes. Go ahead.
So
I think it's enabled.
Yes. Can you see my slides now?
Oh, yes, please.
So what I would suggest is, could we not think about this around AI? Could we not think about this around the technology? Let's just think about this as essentially just sharing information in the health sector. Health is the one endeavor that more than any endeavor that human beings engage in needs and depends on accurate sharing of information for there to be success. Think of a situation where if you go see a doctor and you talk to your general physician and he doesn't tell the pharmacy what your allergies are, but says, the man has been diagnosed with malaria, give him malaria medicine. Think of a situation where your primary healthcare center or your tertiary hospital doesn't share information with the folks at the Ministry of Health. What informs policy? What drives the decisions being made? But unfortunately, health is also the one sphere where interoperability has just been so difficult, so really difficult to achieve. But if you think in terms of it, what essentially is interoperability? So I'm going to be using a description that a number of technical people will find rather basic, and I do apologize. But essentially, interoperability is the ability of one or more systems to be able to exchange, understand, and to use information or data. Doesn't matter how we cut it, it doesn't matter the nice, highfalutin language we use. That's essentially what we want to be able to achieve, have systems share the information, understand it, and use it. Now, essentially, interoperability should facilitate unrestricted sharing and the use of data. And in my view, there are two critical components that are necessary for us to achieve interoperability at any level. First bit is political, and that's the one that involves the human beings. That's navigating the necessary bureaucratic channels so you can get the approvals for whatever are your policies or your standards. Then the next component is technology, which is where you're actually deploying digital tech to achieve what you've been approved. Unfortunately, and as usual, is the political component that is the real problem, not the technology component, in my opinion. Now, this is one scenario. This is a bridge that was built somewhere in the States a long time ago, and they started building from both sides of the river. The idea was, we'll speed up the building. Unfortunately, somebody's GPS was off. By the time the two bridges met, they were off. This is precisely what you get where you don't have interoperability. You have confusion, you have a lot of efforts being invested, you have a lot of money being burnt, but you're not really getting value for what you've put in. This is what you get when you have interoperability. I'm sure we have all seen children. And when I talk children, I'm really talking toddlers about 2, 3, 4-year-olds playing. Try it one day. Take 5, 6 toddlers who don't know each other, leave them together in a room, throw some pencils, throw some toys there. Give it a few minutes. All will be peaceful. They would have worked out their own language, they would have worked out their own rules, and they will be having fun. Primarily because it's built on two things. One of them, Nkiru had mentioned, trust. It's built on trust. And the second one is the common interest. They're all there to have fun. They're all there to play. Once we're all unified in where we're going and we have trust, it's easy to navigate and find out what we can do together. Now, there are lots of benefits of artificial intelligence in healthcare. It ranges from diagnosis, supporting decision-making, supporting research, training, but whatever you want to describe it as. Almost every application of artificial intelligence in healthcare is about sharing data. It's really about collecting, processing, sharing, and managing data. So if you are going to achieve any sort of tangible, impactful health information sharing or interoperability, definitely artificial intelligence has a role. But there's a huge danger with artificial intelligence. And that danger is this. It's what you put in that you would get. If we don't have those trusts in place, if we don't have those agreements in place, AI will just create more problems. Now, I'm going to leave us all with one question. Why is it that it's so difficult to achieve interoperability if we all think it's so beneficial? It cannot be about the technology. I see Lanre in the room. I see Ineobong. I see Emeka. I see a couple of other people I know. I see Nkiruka. I see Vivian. I see people who have decades of experience working in the health space, working to push digital technologies to support health. So it cannot be that we lack the technology or the know-how. Ergo, my conclusion is that what we lack is those two components of the political will. First of all, we lack the necessary trust to be able to work together, and we lack the necessary commonality of purpose. Until we address those two, all the technology in the world is not going to help. AI can do a lot of things for health information sharing. AI can check for errors. AI can help with your taxonomy and checking if your data sets are the same. AI can check for duplicates. AI can do so much. But the question is, what are the rules that's governing AI? I'm going to pause here, but I would like you to look at two slides. Two slides. Emeka, Ine, and a number of people in the room may remember this story, Fatima's story. So Fatima has been enrolled in the NHS. She's pregnant. She signed up for SMS notification. She goes into labor and her family texts the local clinic and calls for a taxi. Mary, who is a nurse, arrives at the clinic, looks into the system's EMR, and she sees that a woman who is in labor is making her way to the clinic. Now, during her assessment, when Fatima arrives, Mary assesses Fatima and realizes the baby is in a breech position. She's sort of uncomfortable. She's not very confident to deal with this on her own. And so she goes onto the tablet in the facility, reviews Fatima's chart, looks in the EMR and sees that this is not her first baby. And the first baby too was in a breech position and didn't survive. So Mary is really panicking at this point. And what does she do? Mary, to be safe, goes online and requests a brief consult with an OB-GYN department in a referral hospital. She speaks to the on-call physician. She has a video conference. She has a real deep conversation, and she walks away with a good sense of confidence. She takes that confidence into the delivery room, and by the grace of God, she has a good delivery with Fatima. So Fatima is safe, the baby is safe. Yippee, we're all happy. And then, to close the loop, Mary updates Fatima's EMR records. The EMR records automatically update the necessary civil registration and vital statistics database. It updates the necessary logistics management information system regarding the commodities that have been used. It sends necessary information to the National Health Management Information System. The NHIA is updated. The LGA's M&A officer receives the necessary aggregate. This is Uhuru. This is a wonderful situation we'd like to get up to. Unfortunately, this is not where we are, and we're a bit far from here. But I want you to think about this. The interoperability policies, processes, protocols, and standards required to make this a reality need to be agreed, they need to be mandated, they need to be regulated, and they need to be managed. Now, this is what would ensure that all users, whether healthcare providers or recipients, are able to have confidence and trust in the system and in their applications. So in answer to your question, Emeka, indeed, AI has a role in health information sharing. But after we have defined what we're sharing and what we're not sharing.
Thank you very much. Thank you very much, Shupo, for taking us down that memory lane. So at this time, I will call Ezenwa as well. Ezenwa, you work in the US, and I understand you have a 5 minutes slide. So try and just walk us through your experience supporting several states in the US in their HIE journey, and if there are challenges, just highlight along the line. Please, 5 minutes. Thank you. You can share your screen. You have the permission.
Yeah, sure. Thank you. So as I mentioned earlier, I told you that 5 minutes. I have this is my first time going to be walking under 5 minutes, but I'll try to go through this slide quickly. And the first thing I'm gonna talk about is just a simple use case on where we was earlier and before we got to where we are today. So this is a simple use case of Sami, 30 years old. This is a normal thing we see every day in any part of the world. People can be moving from one place to another, had an accident, get admitted to the hospital, and then once they get in there, they have to be stabilized. Okay, how do we stabilize this patient who is a diabetic patient? And in this scenario, this patient, in part of that stabilization, was administered epinephrine. And this is a diabetic patient. And guess what happened? High blood pressure shoot up. And even also in this scenario, if you look at this, you can imagine how many times a patient get rushed into the hospital and you have to go back and run tests, different medical tests to understand their situation. So these are all costs that we indirectly incur each time a patient comes to the hospital. And because of that, we can get into the next, is the same use case. But in this scenario, what happened is these two hospitals, Hospital A and Hospital B, are literally connected. And with that ability, you can see that Hospital B is better to kind of have a better clinical decision in terms of what they're gonna give to this patient. And also there is a lot of, cost saving because there's no unnecessary cost. And this can only happen when two systems talk to each other. And this is kind of the basic of how we started in US. So, and the next slide we're gonna be looking at is how does this journey actually started? Just considering the use case I already shared earlier. We started during Obamacare. Obama was the champion of this. We have what we call meaningful use. And when I started, everything was all paper record. So most of my job was to help providers to move into electronic health record, where I played a lot of role under what we call vendor selection. So from there, we move into stage 2. And stage 2 is we get to find out that even within this EHR system, some of the models does not talk to each other. For some of you who have worked with EHR system, you have the patient registration system, you have the billing department, the billing system, you have the lab system, we have the radiology system. That was the biggest problem we have to solve then, because this information does not even share within the same network in the same hospital. So that was kind of that point when we start to work in a narrow way of interoperability between systems inside the hospital. And then we move into stage 3, whereby, okay, we have a hospital A and a hospital B who is under the same network, but in different location, but their two systems does not talk to each other as well. And we start to kind of get into different phases. And part of the first phase we did in terms of that integration was using SFTP. And this was when we were manually doing everything. We set up an SFTP environment whereby we put in a particular information we want to share. And then they get that information, they send it to us to back. It's kind of what I called like a hybrid of faxing. So we did that before we went into TCP VPN connectivity to actually move data across the system. So with this achievement, getting these two systems talking to each other, regardless of the vendor, but under the same network, we kind of moved into a very bigger space. And this is where I played one of my biggest role in the US to manage Missouri Health Information Exchange. So in Missouri Health Information Exchange, my job is to get everybody, oh, sorry about that. My job is to get everybody from different network, regardless of your organization, regardless of your EHR system, to be able to exchange data through the HIE. And this HIE is being funded by federal funding across all states. So that is to say that the state plays a big role in terms of making the health information exchange and this interoperability to actually work. And this creates a lot of benefit in the system. It reduces cost, because cost is the biggest thing in America. Anytime you see America trying to make a lot of innovation and all this kind of stuff, first thing you have to bear in mind is they are trying to cut, there's somewhere they want to reduce cost and reduce inefficiency. So this is how we got in here. I was able to onboard different providers from different networks, and we did that through setting up different interfaces, which is the ADT interface, which is the admit discharge transfer, which most of you in this room know. The SIU, we did that in the SIU, and the goal of the SIU was also to remove to reduce appointment visit, because sometimes we have all these public health workers and community health workers that are managing patient population. They want to know when patient misses the appointment so that they can be able to reschedule. So that really helped to get that holistic view of the patient's record. And with all this stuff, I won't tell you we didn't have any challenges. We had a lot of challenges. And one of the challenges we have was patients duplicate. We have a lot of duplicate when it comes to patient information. We also have standard-related issues as well. And also we have interoperability challenges. And that's going to get me to my next slide. So this is a simple use case in Nigeria, because a lot of people in the room might be asking, why standard? What is standard doing in all these slides that you're sharing? In Nigeria, we have Hausa, Igbo, Yoruba, just picking up the big, group. Do you know the standard we interact with? English. Because without English, I believe nobody can seamlessly kind of talk to each other, understand what each other is trying to communicate on. And also, without this standard, how do we interact in mocks? How do we talk to each other in church? How do we deal in the market and in schools? And this can tell you that standards plays a role with interoperability for us to be able to have great communication in these different areas. And then, still part of the challenge that I mentioned earlier, which has to do with interoperability, is we notice that people will say, you follow standard, but do you really interoperate effectively? That's the next question, because that's the biggest thing you guys gonna run in Nigeria. Everybody will be like, I follow this standard, but still they doesn't talk to each other. So if you look at part A, this is a simple thing that happens in Nigeria every day. Somebody will meet somebody, how you doing? And what they are trying to say is, how are you doing? And the symbol here is, I'm kind of doing translation. This is what we have to do every day in America to convert system that says they follow standard to actually meet the actual standard on how we are serving data within our system. And this is this is kind of like a feedback mechanism, because in the other side, the person responds, I'm doing fine, but you have to put it in such a way that whereby the receiving system will also know that I did okay, which is the said process on how they are understood what standard means for them. So in this area, you can say that this person can still defend that they follow standard. You know why? Because how you did look like English as well. But that's not kind of the way we really want to exchange it. While considering B, this is kind of a seamless conversation between two people. So there is no intermediary translation of information. So interoperability is 100% and they are in conformance.
Thank you. 30 seconds. Are you done?
I think remaining one thing. So another thing is, if you look at slide A and slide B, one of the things that we have done is looking at A, we have to do a lot of conversion of moving data from one point to another, which was a big challenge for us in HL7. And in FHIR, we are able to seamlessly interact, with each other. And this kind of reduce the number of time we spend in updating system, ETL, transaction, and all those kind of stuff. So ongoing work that we are currently doing I'm currently mapping most of the data that we have in HL7V2s and CCDs into FHIR so that that can be exchanged in the HIE. And the same way, all these organizations that I have onboarded, they are doing similar work so that we can really interpret, effectively. So I think that's it. I don't know if you guys have any question.
Thank you very much. Thank you very much, Ezenwa. And it's really good to hear from you and your experience working in the US. It's also good. Everybody in this room are happy to learn from that experience. I'm sure there will be time for question. At this point, Yusuf, I will come to you. You work on e-prescription. Is it just in a short few 2-3 minutes? Let us know what policies and regulatory frameworks or standards that you use as part of your everyday work, especially as you do e-prescription in Germany. Over to you, Yusuf.
Good afternoon, everyone. Permit me to just stand on existing protocols and just continue. Yeah, I over the past 2 years, I've been working with FHIR while working on e-recept, which is what the Germans call their e-prescription. And it's been an interesting ride, to be honest, because there are lots of moving parts. First, when it comes to the actual data that we want to exchange, that is the prescription for, let's say, a particular patient, the standard used for this is, of course, FHIR. And that is perhaps the easiest part of everything. Even though we have our data that is not conformant with FHIR or as at now, so we have to do a lot of mapping. Despite all this mapping and the challenges that come with it, I still think that's the relatively easier part. The other parts involved are things that have to do with authentication, because in Germany here they have their telematic infrastructure, which has been existing for a while, and the method of authentication is not something that is standardized as maybe OAuth and so on that people are quite familiar with. So you have to go with this kind of authentication that is built specifically within this German context, and it's a lot of I guess back and forth and so on, because we have to authenticate with 2 or 3 systems in order to exchange the e-recept bundle. So this was, I think, a little bit challenging. And then there's also the parts that have to do with encryption and signing of the data that you want to exchange. When it comes to the encryption, the encryption scheme also is very German specific also. They're using a particular encryption scheme that you wouldn't find in too many places. It's not too dissimilar from what we use in Bitcoin, because it uses also the elliptic curve. But the algorithm itself is something that we had to basically research more into, because you don't find the implementation across all encryption technologies. So I guess the bottom line for the most part is that the German system is quite robust, but also not the most friendly to deal with. And for us in Nigeria, I guess it's something that we can leapfrog a little bit, because we are coming at a time when there are interoperable way of doing things, and we can just go with what is the latest technology. And we don't have to maybe go to the extreme by picking something that is too next gen or too futuristic, but we can at least kind of leapfrog some of the problems that you can face while dealing with the German telematic infrastructure. I hope that answers your question.
Yeah, thank you, Yusuf. You will agree with me that Yusuf is speaking like a techie. So Yusuf, there are a lot of public health people in the room. When you are speaking encryption, algorithm, and all those things, you've lost many people. But anyway, for the public health people to agree to come to a connectathon, it means they are ready to mingle with us. So thank you for bearing with us there. Anyway, let me transfer to a less technical conversation. So Bulu, you work with the Lagos State government. You work with Chai, and Chai is supporting the Lagos State government, also have a lot of plans to support at the federal level with digitization, interoperability, and all of that. What have you learned so far regarding the readiness, information sharing capacity? You've heard the conversation happening in the room, technical, human, political, policy-wise, regulation. What have you learned in that process?
Yeah. All right, thank you, Mika. Okay, so I would, in terms of digital readiness, I would categorize, into three arms, patients, service provider, as well as the policymakers. We did over the years, we've seen the adoption of mobile phones, the also penetration of internet access, as well as a lot of people are online right now. At least most people use WhatsApp, Facebook, or any other social media application. All right, for the patients, from patients' perspective, right, we believe the patients are ready to adopt the use of digital applications, or like personal health record applications, or digital platforms, so that they can access the patient's record. However, we know like the financial system where you have multiple bank applications, right? Most people are moving. Most people are nomadic these days, which means that because there is no interoperability, there is nothing. You need to have like 5 or 6 mobile app applications for the different facilities you go to, right? Which obviously is not sustainable. In one, your record is just duplicated across board, and 2, you now have more applications from different facilities stored on your phone. So the adoption there is limited, and also the awareness is not to there. For the patient, from the service provider perspective, we actually did a survey. We had 82 healthcare workers in the room. We did a survey on digital readiness, which cut across 4 categories: the core readiness, the learning readiness, the technology readiness, and societal readiness. Well, in summary, what we could find out is for the healthcare workers, they are not open to the technology readiness, as well as the use of this technology in their day-to-day activities. And we can fathom why, right? Things like, one, you still need to, for record keeping and also sharing data to the national level, is still done manually, like the NHMIS register, for example. So even if you are collecting patients' data on the system, right, you still need to do the manual work. 2, things like enabling environment, right, internet connectivity, power issues, right. These are problems that will still allow you to use duplicate ways of entering record manually and electronically. So for the patients, they are reluctant to use it right now because of all these challenges. However, one thing we found out, which is very key, is they are willing to learn. When we saw from the learning criteria, we saw that the healthcare workers are actually ready to learn to use these digital technologies if the enabling environment is there, and if the likes of, and which is coming into the third category, the likes of policies and likes of digital transformations happen to ensure that they don't need to enter manual or field manual registers. And again, that speaks to the third category, the policymakers, right? The government, whether at state level or at national level, right? Yes, we have policies in terms of managing data and the likes. However, now that we're moving into digitization, right? Some policies need to be updated, but also there are some laws, like some bills, right? Also needs to be passed to ensure that at least this digitization effort is able to come into play. Now, for information sharing, I think we've discussed that everywhere. There are silos of system again within the primary health center facilities. And one thing we've also found out is the solution providers, they don't understand the ecosystem before deploying solutions. One thing we see is, yes, they go to the health facilities, they deploy a ready-made solution, but for the information flow, right, it doesn't stop at the health facilities. The local government needs access to this data. The state government or the federal level, they need access to the data. However, we want to find out is there is no system that relates to both the healthcare worker level, the facility level, as well as the LJ level. Most times it's digitized at the facility level, but going to the LG level, it now goes to manual. And at the end of the day, when you have all of this data scattered everywhere, how can you make evidence-based decision or data-driven decision? So in terms of policy, policies need to be in place, frameworks need to be in place, and also the mandated authorities that need to ensure that these EMR solutions comply to standard need to always do like this checks as well.
Thank you very much. Thank you very much, Bolu, for giving us the state of things in Nigeria. So we've listened to global state of things when it comes to health information exchange, and Bolu has gone over to tell us, especially given his work in Lagos State and at the national level. So I'm going to switch gear a bit and call on Engineer Lanre, who is the director of software at NIMC. We all know NIMC. We know that there is a mandate that we should use NIMC. And NIMC has recorded a certain number. We don't know. He's going to tell us about that. And I think you have a slide. So if you can, we are short of time. So if you can run through the slides, but try to highlight how what are some of the partnership that some of the health sector partnerships that you're already forming as part of your slide presentation. So I think your slide is up there. I can bring the pointer. Okay.
Thank you very much. Good afternoon, everybody. I bring you greetings from the DG, CEO at the National Identity Management Commission. So, as you rightly said, the moderator, is there anybody in this room that doesn't have an NIN? Maybe we'll start with that quiz. Okay, nobody. So I think 90% of my job is done. Okay. Because we talk, and forgive me, I might not use the slide because I think it's a known thing. Everybody knows about NIN. So I can roll out some numbers for you and the importance of NIN and how to collaborate in the electronic medical record and in the health sector generally. NIMC is formed by the Act of the National Assembly, and we're all law-abiding citizens, and that's why we all have our NIN. But it's beyond that, and I've listened to all the presenters, and there's one thing that is missing. That's the unique identifier to actually make all this, our good work that we're doing, come together. Okay, I've heard about silo databases, I've heard about different terminologies, but one thing is certain: the electronic medical record points to a human being. And because it's a human being, they need to be uniquely identified. And the only way you can uniquely identify the human being is through their biometrics. And there are 3 modalities that we use at the National Identity Management Commission to identify a human being, to uniquely identify a human being. We use the face, we use the fingerprint, not just the fingerprint, we use the 10 fingerprints. And not just the 10 fingerprints, how do I put it? We use some intelligence in capturing those 10 fingerprints, not just one at a time, but combinations, because we're a very difficult society. We like to break rules. We like to manipulate systems. And it's not a bad thing. I think we are overtly intelligence. So in that way, we have to also try to make those challenges to have the 442 scanners. They are very expensive, but again, it is good for the country and good for the future. And the third modality is the iris, which we are about to deploy, another expensive, which has the most level of accuracy, which is 99.99% accuracy. Okay. So so what is the NIN? The NIN is an 11-digit unintelligent randomly generated number. What do I mean by that? So if all of us on this panel, we are at the same center trying to register, his number can start with 175. My number can start with 983. And so it's randomly. The essence is that so that you don't get the center where it was registered, so that you don't discriminate because it's registered in Kano and you want to be verified in Lagos, you want to disenfranchise him. So it's random. Okay. And so if you can move to the fifth slide. So once you have the NIN, why is it useful to you, especially the health sector? You know, you need to be able to verify those NIN. So there's a verification service that is deployed by the National Identity Management Commission. The techies in the house will know what an API is, application programming interface. What that does is allow you to consume our services behind the scene using a call, okay? So it gives you the flexibility whereby you can develop your own application and make sure you are able to link up with the National Identity Database to verify those names. And also we have the USSD service. The USSD is the service that you can use through your phone. It's not a smartphone. You dial your *346# from the phone that you use to enroll, and you'll be able to retrieve your NIN. Why is it from the phone that you use to enroll? Because we had people, you remember I said we are overtly intelligent. Somebody actually keyed in Dangote's number and pulled his name. How does he know Dangote's number? He pulled Dangote's date of birth from the internet and used his first name and last name, and he was able to retrieve his NIN. So we had to stop that option. So it has to be from the phone that you use to enroll to be able to retrieve your NIN. And also we have a mobile app on the Play Store. You can download our mobile app whereby also you can print your name slip and be able to enjoy all the services. Okay, I've talked about the API. Also, we have the desktop application in case you don't have in-house developers, you want to consume the verification, we can deploy an application for you. Okay, I'll discuss about the mobile app. So, what is in it for you as providers, health providers? I've heard people talk about electronic medical record. In the US, it's called electronic health record. And I remembered early 2000, I was also involved in developing electronic health record in the US. There must be a unique identifier, okay? There's no doubt about it. Otherwise, you have your agencies develop electronic medical records in Lagos State, somebody develop in Ogun State. Because we are smart, somebody in Lagos will come to Ogun to enjoy the services in Ogun State. But if you use a database that cuts across board with the NIN does for you, you will be able to identify, even if you come from Maiduguri, that yes, you are so and so in Maiduguri. Why are you here? What do you want? Okay. So I guess I have 1 more minute. I think I'm done. So
Thank you.
So remind your family and friends the importance of the NIN so that you can all enjoy the services today and into the future. Thank you.
Thank you for that wonderful presentation, sir. I have an immediate question for you, and I'm sure many developers in this room have a question. Maybe this question will address your question, George. This question is, what is the criteria that developers will meet to consume your API? as like EMR or EHR developer. They have developed their system. They want to consume your API to authenticate identifiers. Thank you.
Okay, thank you. As a government agency, right, we supposed to provide services for free especially to be able to encourage developers to develop the application for the future. So we do that. We can provision the API documentation to you in test environment. As a matter of fact, we are thinking of doing a hackathon so that we invite developers to come and consume the services and see how they can move to the next level. So yeah, there are processes and procedures, and you can also visit our website to get some of this information. Thank you.
Thank you very much for that. And I'm sure they have answered many questions that would have come your way. I will go back to you. Matthias. Yes. Matthias, as we are discussing this, you are a cybersecurity expert. You've also worked on an ID for D development in Nigeria, meaning you know our problem. Please tell us, what are the challenges we should envisage? Please speak more to the cybersecurity aspect. Thanks.
Thank you very much. Thanks for the opportunity to be here. Thank you, sir. And thanks, everybody. We have a couple of issues. And let me start by asking this question to the house. If you go to your doctor today and you are diagnosed of something, and tomorrow you find out that what your doctor recorded or the information you gave your doctor, your health record, is publicly available on the internet, how would you feel about that? Nobody will be comfortable about that. One of the major challenges about what we are building, especially not at the national level, you see, it's easier at the national level, at the top level, to adopt standards. I mean, you have the resources, you have the money, you have, you know, the, how do I say, the government breathing down your neck to say you must follow this standard. Now, look at a startup that is started by, or that is just starting, health operator or a new startup building an amazing software by some group of new graduates, and they found a small office, and you know, maybe they just raised about $50,000. It's a lot of money to them. To you, it might not be. Now, security to them is an afterthought. Many times, from experience, most times when we're talking about building systems, using technologies, many times, even from history, security is an afterthought. One of the major things that we need to look at, and I love the fact that Mayoga mentioned something, lessons that NIMSI had learned. We've worked closely on a couple of things, so I know some of these lessons. For example, he mentioned something around the collection of biometrics data. Now, Nigerians were very interesting people. At first, when it came to collection of biometric data, you're supposed to put 4 fingerprints, right? But people were mixing it together, so which made your identity not to be unique. Now, my question to you is, you are a $1 million organization. You have a lot of money. You've built an amazing software solution. You've built a system. You have your data. Your patients are happy with what you built. Now, here comes a startup, or here comes another organization. They want to plug to your system and take data from you. How comfortable would you be? The issue of trust and security. Now, the problem is not that you can't give them the data. The problem is if the data gets breached in the future, your patients will come to you because it's you they registered with, not the provider. And we have this scenario playing out largely right now in our ecosystem, especially the tech ecosystem in Nigeria. The fintech ecosystem, for an example. The banking data record is supposed to be sacred, right? A big bank, you know, the big banks, they keep the data record, they keep it sacred, doing data privacy, doing security, pulling their weight, doing everything possible. Now, an organization is doing little when it comes to security. They connect, they take the data, they do whatever they like with it. When a data breach occurs, it goes back to the main organization that gave them the data. Now, one of the major ways to solve this problem is to ensure, and if you've listened to my colleagues that have spoken concerning how the NHS system in the UK work, the German system, the US system, you will notice something that they have, a centralized system. So if I say that 5 organizations here should build different systems and have all the 5 systems connecting together, it will create a lot of noise. It's difficult. But what makes it easier is when you have a centralized national system. For example, we have the national identity system. If you want to do anything that has with identity, just connect to it. Now, if you go that approach and say you have a national health system that allows everybody to come plug to it, your data goes to that national system, then there can be more enforcement of standards at that national level, which will spiral down to everybody, no matter which level you are. This is what the banking industry in Nigeria has done. That's why we have the NIBBS system. No matter the bank you are, you must follow that standard. However, if you had said that let organization A, B, C, D, E, F, G, H start interconnecting, you will have a lot of problems that you need to solve. We need to solve this problem of trust by having a national centralized database that will adhere to standards, international standards. Our data will be trusted at the national level and international level because you just need to plug country to country. Now, organizations only need to worry about maintaining standards that national level has given. And then you plug your system, you plug to the system, you share data with that system, adhering to the rules. And we need to ensure that we know the responsibilities of whose responsibility is to protect what data and at what level. These are the things that we need to come and we need to put in place. This will solve the trust issue that we've been talking about. It will improve the trust issue that we've been talking about. And it will help us to have a standardized data sharing, much more secure environment. I can trust that if I go to your hospital, I put my data for you, it's going to the national, not to someone beside you who may not take security seriously. I know that the people at the top will breathe down your neck. And I know that I am much more protected. That is one thing that I wanted to talk about.
Thank you.
And also, more importantly, Maoga says something. Sorry, I'm using the word Maoga. Data means people. We're not protecting data, we're protecting people. Every time you collect a single data, you are interacting with people. This data matters to the people. What you do with the data is very, very important to them. Now, when we have large data like this, how do we protect and secure the people who owns this data?
Okay.
That is the next question we should be asking.
Thank you very much, Matthias. You have highlighted several discussions that I'm sure there's a lot of questions waiting, but I will not ask any of them. I'll just move on to call on Ezenwa and Yusuf. You can just take a few minutes, 1 or 1 minute and a half to try and address the question of cross-border data sharing involves complex legal and privacy considerations. What legal and regulatory challenges have arisen in the context of HIE, and how have these been addressed in your respective countries, so the US and Germany? Ezenwa, you first.
Yeah, sure.
90 seconds.
Yeah, sure. So in the US, currently, one of the biggest fights we had was we have to deal with consent. Consent was a big problem that we had, even up to today. For example, we have a consent policy, which we call opt-in and opt-out. So a patient has the right to opt in for you to be able to share their information. So that was how we started. And also part of that, we have a report that we run internally, which is called a disclosure report. And this is being run on different, this is kind of part of that processes that we had in place, at the beginning of, implementing all this EHR. This allows you to see who accessed the record, from what department, did they have the right to access the record? Are they the providers? Are they the primary provider for that patient? We create this report every day within our organization. And whenever we see anything that looks funny, that we have to report this to the compliance department. So this is kind of that process we have in place to be able to make sure that patients' records are being protected. That issue of HIPAA, which most of you know, the privacy, security, and confidentiality of the patient's record has been, maintained. So any record you see in the HIE, the patient opting to their information to be shared within the HIE.
Thank you.
That's how we manage.
Thank you very much. Thank you,
Yeah.
Ezenwat. Over to you, Yusuf. Cross-border policies and regulation in Germany. Thank you.
When you go to a typical hospital in Germany, you have your card. This card is like is your insurance card, and the practitioner also have their own card, which is more or less issued by the body that manages doctors. And at the hospital, they have a card terminal, which is attached to another machine, which we call a connector, which is attached to the German telematics infrastructure. So if you were to visit a practice or a hospital, since everyone is insured in the country, even if you are coming to Germany as a visitor, and you would probably buy some insurance with a policy with some company, it could be Mansard also, any company, some companies in Nigeria also offer that. So in a way, if they have your card and they have their card and they insert the two cards in their machine, there is some implicit understanding that this is somebody this is a practitioner who is trying to access the information for a patient who is at this moment in their practice. So, and the whole authentication and so on is handled, and the whole system of authorization and authentication is handled and behind the scenes. So there is this implicit understanding based on the presence of these two cards in the system that this person is allowed to access this practitioner is allowed to access the information for this particular patient. So, of course, this is possible because everyone has an insurance coverage, and they can get to the practice holding their card and being able to authorize the practitioner by handing their card over that, hey, this practitioner has the right to access my information. So yeah, that's how it works.
Thank you very much, Yusuf. So I come to you, Shuko. AI predictions can sometimes not be accurate. And of course, sometimes it can even result in harm. And in the context of data coming from multiple sources, what safeguards can or should be put in place to ensure safety, even trust in AI system itself? Over to you, Shuko.
Okay, so the first thing that needs to be done is we need to define exactly what we want to achieve. We need to be very clear. AI, like any other technology, is essentially an enabler. Doesn't matter how sophisticated it is. It's essentially an enabler, and it's enabling a process within some parameters that we define. So, for example, one of the things AI can do for you easily in looking at data is, for example, you can set AI to look at copious, massive amount of volumes of data and quickly flag for you if there is personal identifier information that's part of a data pool that's about to be shared. AI predictions are not always accurate. They will never be always accurate. They're as accurate as the training data, they're as accurate as the testing we do. The major way to address that, in my opinion, is to operate with some simple ethical rules. One, the data set we're using to train an algorithm, is it representative of the target data? It makes no sense to go capture data from across tertiary institutions in Nigeria, tertiary level education institutions in Nigeria, and want to use that to model something that I'm going to apply to secondary school children. So the training data, the data with which you build your system, your algorithms, needs to be contextually relevant to your target audience. That way, there's a lessened chance of errors. We need to be able to aggressively and actively check for things like algorithmic bias. Are there biases we're programming into our algorithms just because we think that way? More often than not, if you say nurse in Nigeria, in most of the global south, people think in terms of a female. So if someone says, Emeka, go into that room and please ask the nurse to come, not the doctor. If there are 3 women in the room and 2 men, more often than not, the person will go into the room and turn to the women. It is possible that the women are doctors and it's the men that are nurses. So these are inherent biases that we're not even conscious of. So it's just aggressively and actively checking for this. And then most importantly, somebody was talking about reports, disclosure reports they run on a daily basis. Yep. Most importantly, recognize the fact that AI could be fallible and check for errors, check for issues on a continuous basis. If I check my system today and it's working very fine, then I run 3 million pieces of data through it. In 2 weeks, it's not the exact same system I had today. My error margin may have changed.
Thank you.
My system may have learned new things.
Thank you very much, Shupo. We are out of time. They are breathing on my neck. And I will just give each of you 1 minute, Lanre and Bolu, to try to talk about how ID can impact health insurance and social protection.
All right, thank you. So with the use of health ID, yeah, it's a great long way into ensuring that one, for the patients, they have access to their historical records. And again, this nomadic movement that is happening right now, you have this record with you, and you can go to any health facility, share with any facility that is leveraging this FHIR standards or health ID related standards, and ensure that, yes, that continuity of care continues. Also, in terms of insurance, right, it's also key to ensure that the same health ID is connected to the insurance care. And again, the time wasting, the claim management, the whole process in terms of interaction between the EMR and the insurance systems becomes more seamless with this health ID. And also with health ID, the data now becomes meaningful for people like researchers. They're able to leverage this data and be able to, maybe for pharmaceutical companies who have sent clinical drugs, they're able to get feedback because now every data is unique and they're able to make sense of this data.
Thank you very much, Larry.
Yeah, thank you very much. I want to ride on all he has just said, but most importantly, not just ID, but unique ID, because you want to ensure transparency, accountability, and saving costs. So if you're able to get uniqueness of individuals, you'll be able to make more progress. Thank you.
Thank you very much, everyone. And apologies, we have 6 people panel. So we're trying to squeeze the time. We're really happy that we're able to share your experience. Thank you,
let's see, actually, if you have you taken questions from
Okay.
Yeah, I think there might be 1 or 2 questions from this panel. So let's take some questions, very short questions, please, guys, so that we can wrap up on time. We'll take 2 from the room and then see if there's anyone online.
Okay. All right. My question is to the Director of Software Development and Biometrics. Recently I worked on a system for a South African organization where we had to validate the South African ID. And for that validation, I didn't need to call any API. There is an algorithm out there that you can use to validate a South African ID without like making an API call. Is this something that your organization is considering? Is this something that, because given the fact that, that over here we have problems with reliable internet, and all of that, having to always make an API call to validate an ID might become a bottleneck. I mean, are you really looking into some of these other means of validation of the NIN? Thank you.
Yeah, absolutely. Thank you very much. And again, we are not South Africans, we are Nigerians, right? But that much said, we have the QR code as well. You can use the QR code to validate. And on the card, for those who are lucky enough to have the token, which is the card, it has an embedded chip, whereby if you have a card reader, you can instantly validate those cards also without making an API call. Again, but regardless of what solution you use, the most reliable for a large population like ours, already 102 million records, you will still need to have an API. So maybe for the services that you were trying to validate at that point, those algorithms work, but we do have a QR code also, which is also based on algorithms to make validation easy. Thank you.
Okay, thank you very much. My name is Ayo, and I work with Health Services and Environment Secretariat, desk officer for eHealth. My question goes to the presenter, though I didn't get his name because I stepped out. The one from Missouri that is working on the Health Information Exchange.
DK.
Yes. So from his presentation, I saw he was definitely talking about the Health Information Exchange layer. So I want to, is it possible to still achieve interoperability without the HIE? I thought that was what FHIR was going to address. So now, can he explain, since he's been working practically in this field, if can interoperability be achieved without the Health Information Exchange as a layer in the process? Thank you.
Ezenwa, over to you.
Yeah, sure. So technically, the HIE is already there to stay. FHIR is actually, because currently we exchange with HL7 v2.5. So FHIR is actually helping to make interoperability better. That's what FHIR is doing. So, but with the HIE is, instead of having one, let's say we have 200 EHR system. Instead of telling those EHR systems talk to each other independently, the HIE helps everyone to plug to one engine. So there will be one efficiency, improve clarity, and also speed in exchange of information. So instead of having all wires all around to talk to each other, you just have one system everybody talks to, and everybody gets that information with. So to kind of answer your question very better, FHIR gonna make interoperability better, because that's kind of the reason why we are moving to FHIR. Because with HL7, we had a lot of challenges with interoperability with different systems. So with FHIR, it's gonna make it better. It's gonna also improve the HIE systems.
So Ezenwa, so you have one HIE in the US?
We have one HIE in Missouri. So in Missouri, every state has their own HIE. And across each state, for example, in Missouri has their own HIE. And I also work in what we call Regional Health Information Exchange with Nebraska, Kansas, and Arkansas. So we have Regional Health Information Network because some patients live on the borderline across each state. So those Regional Health Information Network is 2 HIEs from 2 different states talking to each other. And then from there, that's why we are moving into the National Health Interoperability Network, which is trying to get all HIE or all regional HIE to exchange data so we can see holistically across the whole country. So, but right now, every state has their own HIE. Yeah.
Thank you so much. And my appreciation to the panelists. Thank you so much for your time. Please, let's give them a round of applause.
Thank you.